The first two questions will be responded to by Kathy Roby. The first is, please, can you go over M2005, Scenario 1?
Okay, just think, it's a marathon and you made it. We're almost at the finish line. In practice scenario 1 for 2005, the first question that you're answering is 2001. In the scenario, it says, during the start of care comprehensive assessment, the RN completes the drug regimen review and identifies a potential clinically significant medication issue. Therefore, the answer to 2001 is yes. On that day of admission, the nurse calls and leaves a message with the physician's office related to the issue. The physician does not return her call until after midnight of the next calendar day. No other medication issues arise during the episode, and the patient is then discharged from home health. Based on that, M2003 is answered no, because the physician's contact was not completed two-way, so he did not respond until after midnight of the next calendar day. The final question, M2005, is answered no. The reasoning is the start of care issue that was identified, the physician was contacted, but the call was not returned within the time frame. And so for that reason, 2005 is answered as no.
The next question, also for Kathy. Please clarify the difference between the speaker's instruction on Wednesday that the clinician could use the physician's record of the patient's weight at SOC prior to casting of the fracture in her scenario. The two existing Q&As for this item indicates that the assessing clinician must measure the weight and that documentation from another provider may not be used. Would the clinician enter the dash in this situation as the patient's true weight, as the patient's true weight is not available at the SOC visit?
The M1060B question on the OASIS form includes the phrase, within the last 30 days. The best example to understand how this applies is the patient is admitted. The start of care is that day. The patient is weighed on that day by an agency clinician. The weight is entered in 1060B. On a subsequent date, the patient is transferred to the hospital, returns home several days later with a new cast, rendering patient now unable to be weighed at resumption of care. The start of care weight that was obtained within the last 30 days of that resumption of care by the agency, the same provider, does meet all the criteria in 1060B. Weights obtained from another provider source would not be acceptable. So we think the confusion is in practitioner-provider. It doesn't have to be the same nurse between start of care and resumption. It does need to be the same provider. So that if there was a start of care, you obtained the weight then, something happened, and at resumption you could not get a weight, You would not be entering anything else. You would use the date, the weight from the start of care, if it is within the same 30-day period. I hope that answers that one. I know it's very confusing.
Also joining me on stage, who you may hear from in addition to Kathy Roby, are Ann Olson, Ann Spinard, Jen Pettis, Joan Proctor, and Stace Mandel. And Julie is still with us from Telegen via phone. I'm scrolling back up. M1060B says you can record the most recent weight in the last 30 days. If my agency weighs the patient at SOC, then the patient is transferred and care resumed. On the ROC, can the agency use the same weight from the SOC if taken within 30 days? Yes. The answer is yes. On the ROC, an attempt to weigh should be made if this is not possible and the previous weight is within the 30-day window, the weight can be used. Next question. Must we weigh the patient on SOC, or can the information be obtained from the MD or hospital? A previous webinar stated we must do it on the SOC visit and it cannot be obtained from the record, but the OASIS question reads, quote, most recent in the last 30 days. The response on the SOC, an attempt to weigh should be made. If this is not possible, then the previous weight in M1060B is within the 30-day window. The weight can be used. Next question. I understand the need for PAC consistency in using the first assessment findings. However, leaving a pressure ulcer as unstageable due to non-removable dressing, even when we have an opportunity to remove the dressing for actual assessment in the 5-day window, has other implications with respect to payment and would impact M1313 later in care. Can you explain how to reconcile those two issues?
So I guess that one's mine. Let's see. All right. So in M13, in M1313, we must code based on the initial skin assessment closest to your start of care. And that is consistent. I know that people are going to struggle with that, but you know, you have your 5-day window, so when you do your initial skin assessment, that's when you have to code what you have for that assessment. And we encourage it to be as close to the start of care or when you take on that patient.
Next question. The OASIS C2 still does not have an OMB number. When will the OASIS C2 receive approval from OMB?
We are aware of the problem that this is causing, and we've reached out to OMB, and it has been elevated up the line in terms of our agency trying to get a response from them on a timely basis. And every issue that I get, I'm sure to share with them so that it kind of reemphasizes the magnitude of the impact on you as providers. So as quickly as we can get it released, we will. I will say that last go-around of OASIS C1, it was released in mid-November, right before the rollout. So we're running a little bit later than that, but we do understand the urgency.
Next question. When the clinician chooses an answer for the goal on GG0170C2, is this just an opinion based on the assessment? Will it affect any outcomes if the goal chosen is not reached?
So the discharge goal for GG 0170C2 is a consistent measure that's included in all of the post-acute measurement tools, and it's used, as we've talked about, as a covariate and a risk adjuster to the percent of patients with pressure ulcers that are new or worsened quality measure. So in answer to the last question, will it affect any outcomes if the goal chosen is not reached? It will not. It is affecting as a covariate and a risk adjuster for the percent of patients with pressure ulcers that are new or worsened quality measure.
Next question. Please clarify. If the pressure ulcer is identified as a stage 3 in the SNF documentation, but is under a dressing that cannot be removed at the SOC, for M1311, do I identify a stage 3 or unstageable pressure ulcer due to non-removable dressing? I thought I heard it stated that the pressure ulcer remains the same stage.
Okay, so basically with this particular thing, so if it's a non-removable dressing, you also got to make sure that we're not just saying, oh, it's got a dressing on it, so we're not removing it. It should be like a primary surgical dressing where you have an order, you have a reason that you can't remove the dressing. So first and foremost, clinically, if you can remove the dressing, remove it and replace it. You know, clean it, assess it, and score it, right? But you will occasionally get a primary surgical dressing or something that you actually have orders that said, please do not remove until whatever date. Then you're not allowed to remove that dressing. You're following physician orders. So I think some people are saying, oh, just because it has a dressing, I can't assess it. So that's probably a point I should have made earlier, but go ahead and do that. In this particular situation, if you had an order that says you cannot remove that dressing, so you can't get in there and assess it, even though that you knew it was a stage 3 from the previous setting, that's good knowledge to have, but you have to stage it as unstageable due to non-removable dressing. And then later on you'll have to identify it. So hopefully those should be few and far between. We don't have a lot of things, unless they have a cast over it, or again, a primary surgical dressing or something like that. It shouldn't be too often that we're seeing that.
When a patient has diabetes and PVD/PAD, this is coded as E11.51, a combination code for diabetic PVD. Are you saying to only check diabetes because there is no I code, I-73, etc., even though the patient has both diabetes and PVD? Not all diabetics have PVD, and when present, there is a higher risk of non-healing.
There it is. In the start of care, resumption of care assessment, you are only completing what is assessed as present upon admission. And wait a minute, that's an ulcer question. Where is it? You see, that's the answer. That's an ulcer response. That's not the correct one. We're going to have to take this one back because the answer that's placed in here is not relative to that question. So we will have to take it back, and it will get answered and posted. Because that's not the correct one.
Do I have the correct understanding for the second row in M1311? Row 2 is only coded at follow-up, parenthetically recent or other follow-up, and discharge. If I identify a pressure ulcer in the first row at follow-up or discharge, then I go to the second row and identify how many of the pressure ulcers in the first row were present at the same stage at Sauk Rock. For example, if I have one stage 3 at follow-up, I look back to Sauk Rock and determine if there was a stage 3 pressure ulcer present at that location. If yes, I code 1. If it was not present as a stage 3, I code 0.
Okay. So just remember, so on your Sauk Rock, you're filling out the A1s through the F1s, okay? And at the discharge transfer, discharge and follow-ups, you're doing the A1 and the A2s and the B1 and the B2s. Okay, so in the follow-up and discharge assessment, you're asked how many of the ulcers at each stage are present upon admission. The next question asks you if these ulcers, how many are present upon admission. So in the Sauk Rock has one stage 3 ulcer and no other pressure ulcers, I'm assuming, because that's the way it's described. And then at discharge, there is still a stage 3. You would code B1, would be coded as 1, okay, because Sauk Rock we had one. And B2, it says, of those stage 3s, how many were on, or how many we currently have, we have B1 is we have 1 on discharge. And then in B2, it says how many of those were current at the Sauk Rock, and you would do 1. So in that particular scenario, it's 1-1. They would have a stage 3 at Sauk Rock, and then of those, they had 1.
At Sauk, as the assessing clinician, I determine that my patient does not have an active diagnosis of PVD, PAD, diabetes mellitus based on his report, and I leave both rows blank. 2 days later, I realize my patient was a poor historian, and I receive additional information from the transferring facility identifying the patient as having diabetes. I reassess my patient in another visit during the 5 days after Sauk and determine that diabetes is an active diagnosis, and I will be checking blood sugars. Even though I had previously completed my assessment, since I had incorrect information, I will follow my agency correction policy and change my response and check row 2 DM for M1028. Is that correct?
Upon obtaining the additional information from the transferring facility, the clinician should verify that diagnosis with the ordering physician. If confirmed, and because this is within the 5-day window, the clinician can amend the coding according to the agency policy.
A presenter mentioned during the scenario that her friend used a belt to go from lying to sitting up on the side of the bed. If someone had to hand her friend the belt, would that still be considered independent?
So for GG0170C, the use of an assistive device, as we've discussed, does not affect the scoring of the measure if the patient's able to perform the activity independently. If the patient usually requires a caregiver to hand them the assistive device, in this scenario, the belt, to perform the activity, this would be scored as a code 5, a setup or cleanup assistance, because the patient requires the setup assistance prior to performing that activity.
If you have a bed-bound patient on admit Sauk, you code them an 88 for medical reasons. How or what do you code them at discharge if you cannot use codes 7, 9, or 88?
So this is regarding GG0170C, and they're not talking about coding them at discharge, but I believe they're referring to the discharge goal on GG0170C. So in this scenario, with a bedbound patient, if prior to the current illness, exacerbation, or injury, the patient did not perform this activity, in this scenario, again, because the patient was bedbound, the patient would be scored as a code 09. If the bedbound status was new and or temporary, so the activity was not attempted because of this new medical condition or safety concern, then the patient would be scored 88, a code 88. If the patient's expected to gain function, then you would score the discharge goal accordingly using the scale of 1 through 6. And if the patient is not expected that they will regain this function by discharge, the discharge goal for GG0170C2 would be the dash.
Are we permitted to use physician-documented actual height and weight? I'm going to take this one myself. It's a one-word answer, no. Next question, how do you determine active diagnosis for recertification?
The time points for identifying the active diagnosis were listed as start of care and resumption of care only. This is not collected as part of a follow-up or at discharge. The data collection points are SOC and ROC only.
Will GG0170C be used to calculate risk adjustment for other OASIS outcome measures besides pressure ulcer?
So I believe this is similar to the response to the prior question, that GG is used as a covariate to the percent of patients with pressure ulcers that are new or worsened. So it is currently not used to calculate, or it is, currently used to calculate the risk adjustment. It is not, it's currently not used to calculate the risk adjustment for other OASIS outcome measures. It is used as a risk adjustment for risk for pressure ulcers.
If the patient sleeps in an electric recliner, which we are assessing as their bed, if the recliner is electric and the patient pushes a button for the chair to return to a sitting position, is this considered assistance?
I think everyone knows the answer, right? So the answer to that is that if the patient is able to use an assistive device themselves, they would be coded as a 6. So because this patient's able to use the assistive device, being the electric recliner, they would be scored as 6 independent.
When will the CMS web-based OASIS training on the CMS Survey and Certification Group Surveyor Training website be updated to reflect OASIS C2?
We are still waiting a decision from leadership in terms of how that will and who will have responsibility for that. That unfortunately has not been defined. However, one of the things that if you look at the QTSO website you will see is that we did post OASIS C2 questions and answers. So essentially, I would encourage you to go and take a look at our Spotlight page, which directs you to that, and use that as a interim measure to address your immediate questions regarding those new items that we're collecting. Of course, you would, any of those things related to surveying certification do need to go to Janine O'Malley in CMS.
Please clarify the B3 items. Number of these stage 3 pressure ulcers that were present at most recent SOC ROC. If a pressure ulcer is observed at discharge as stage 3, but at SOC it was a stage 2, wouldn't the coding be B1 equals 1, B2 equals 2, because it is a different stage? This is how I understand it from the example in the guidance under determining present on admission, the 6th bullet.
Okay. Okay, so there is no B3 item. I think the question was asking for B3 item. In this example, at discharge or follow-up assessment, you would have A1 equals 0, A2 would be a skip, B1 would equal a 1, and B2 would equal a 0. The reason that is at discharge, there were no stage 2 pressure ulcers. There is one stage 3 ulcer, and then it asks, of these ulcers, how many were present upon admission, and that would be 0, as there were no stage 3 ulcers on the SOC ROC.
Is M1311 completed only at SOC, ROC, follow-up, discharge, not done at transfer, recert, etc.?
M1311 in the start of care, resumption of care, has you answer questions A1 through E1, and discharge and follow-up assessments have you answer A1 through F1 and A2 through F2. So if you go to actually look at those various assessments, you'll see only on the SOC ROC is A1 to E1, and then the others ask of these how many were available. You know, you have to have that look-back period, so it's at the discharge or follow-up.
I see no other questions that have been reviewed and are ready to be answered at this time. If you have submitted a question that wasn't duplicative and wasn't addressed, it will be addressed in the Q&A. And I should mention, every question will receive a response when you receive the complete Q&A. So with that, I think we may be adjourned. Thank you for attending. Thank you for being present, and most importantly, thank you for the care that you provide.